So I'm going to present the next two cases. So Janet initially presented to her primary care physician this past fall at the urging of her daughters. She had been complaining of progressive fatigue for the past 5 months, and Janet attributed these symptoms to taking care of her husband and getting older. So her primary care physician did initial blood work, and in fact, Janet was anemic as well as had some significant renal insufficiency. We can also see in these labs that she has an elevated calcium and an elevated total protein. So she was referred to us for further workup. We did a multiple myeloma panel, and her M spike was 2.5 grams. She had an elevated IgG with reciprocal suppression of her IgA and IgM. She also had an elevated kappa free light chain. So we did a bone marrow biopsy, which showed 75% kappa-restricted plasma cells. Her FISH showed a translocation at 414, and we diagnosed Janet with IgG kappa multiple myeloma with an ISS stage 2 intermediate risk. So a little more about Janet. She is a primary caregiver for her husband, who is disabled from a stroke he suffered 3 years ago. She lives rather far from the cancer center, about an hour, but in New York City, living an hour from the cancer center can easily translate into 3 or 4 hours, so rather far. But otherwise, Janet is generally in good health with a history of high blood pressure and high cholesterol. So when discussing what we wanted to treat her with for her initial line of therapy, Janet expressed some concerns about frequent travel to the cancer center and securing care for her husband while she was getting treated. So we discussed starting an oral regimen of lanalidomide and dexamethasone.
So as Donna mentioned, the different choices that are available can be kind of overwhelming. There was a trial that was called the FIRST trial, which used lenalidomide and dexamethasone and showed that continuous therapy was superior to the 2 other arms. So in this study, patients received lenalidomide and dexamethasone continuous without stopping, or fixed doses of the lenalidomide and dexamethasone for 18 cycles, or oral melphalan, prednisone, and thalidomide. We saw more pronounced benefits in patients less than 75 years of age that had this continuous therapy with an impressive 4-year overall survival. Think of the average lifespan of a 75-year-old is not necessarily 4 years, but we saw a majority of these patients were still alive with this continuous therapy. Another recent study is called the STROG 777 study. 777. And so this study used 3 drugs up front. Remember, Oscar got lenalidomide, bortezomib, and dexamethasone induction. This study compared the 3 drugs versus the 2 drugs, just lenalidomide and dexamethasone. And what you're looking at on this slide are progression-free survival curves and overall survival curves. We saw that people had a longer progression-free survival, meaning they were in remission longer, and we also saw that people with the 3 drugs had a longer overall survival. Now, the enthusiasm of this study is counterbalanced a little bit by the increased incidence of peripheral neuropathy, and then the patients had to come to the clinic as well. And in Janet's case, she thought, gosh, well, if lenalidomide and dexamethasone is a good option for me, I might consider that. One option that was not necessarily presented to Janet was using alkylating agents. So this is another upfront regimen in elderly patients. Again, they're not necessarily elderly, but it was classified in terms of the clinical trial. This study, what you're looking at is the patients receive melphalan, prednisone, and lenalidomide pills, cyclophosphamide, lenalidomide, and prednisone, and then lenalidomide and dexamethasone. And in the context of this study, the alkylating agents didn't provide benefit, so it's probably not a good idea to use this upfront in elderly patients. We would want to focus on the Lendex or the bortezomib Lendex. Another thing that nurses can do in patients that are newly diagnosed with multiple myeloma is to consider their fitness or how well they are in terms of other comorbid indexes. The Charleston Comorbidity Index predicts the individual's 10-year mortality for patients. So what there is there's algorithms online where you can sum scores. You give a point each for if they had a myocardial infarction, congestive heart failure, cerebrovascular disease, liver disease. You get 2 points if they have hemiplegia, moderate or severe kidney disease, and so on. They have various different scores and formulas to assess the point value, but the take-home point is to familiarize yourself with this concept of fit and frailness when you're deciding a treatment. Because as Joseph mentioned before, the importance of shared decision-making, and I love this slide. I love that it has the 3 little bubbles that center around the decision-making process. You take into consideration clinical experience, data from research, and patient preference to make that ultimate decision. Because when you're talking about adherence, staying on treatment, you want to have buy-in from the patient, because we know the longer you're on a therapy, the better the individual will do. And it's a balancing act. So you can see the different parts of this slide that's on balance is the patient characteristics, such as their comorbidities, the efficacy of the regimen, and balance that with administration and chair time, finances. Janet didn't want to worry about care for her husband while she's driving 3 hours down the road to see Donna at her cancer center to get bortezomib. In this situation, it might not have been right for her.
So we monitored Janet monthly, and after approximately having 5 months of treatment, we did a full evaluation, and she had about a 50% decrease in her paraproteins. Janet expressed that she was rather disappointed, as she was hoping to see a deeper response. At this point, Janet is eligible for transplant. However, she is not a good candidate given her family circumstances. So we discussed adding in an additional oral agent to her treatment. So Activism is an oral proteasome inhibitor recently FDA approved in combination with lenalidomide and dexamethasone after 1+ therapy. So it's a capsule that we give weekly on days 1, 8, and 15 out of a 28-day cycle. Should be taken on an empty stomach, so either an hour before or 2 hours after meals. When patients are on therapy, you want to monitor CBC, especially platelets, frequently, so I would say especially during the first 3 cycles. Patients can nadir between days 14 and 21. We also want to remember this is a proteasome inhibitor, so we want to monitor for signs and symptoms of peripheral neuropathy and peripheral edema. And this is a good example of a treatment calendar which I would give a patient. So the Activism, we would start off with a dose of 4 milligrams weekly, 3 weeks on, 1 week off, and the lenalidomide and dexamethasone is standard dosing and scheduling. So for patients who might not be used to taking an agent once a week, this could be difficult, and adherence is very important because we want patients to get optimal benefit from the regimen. And it's important too with the Activism, you can't punch it out and put it in a pill box. It really needs to stay in that blister pack that it's given in. So there are some difficulties with that. So maintaining a good treatment calendar for patients to follow is very important for adherence.
As Donna mentioned, Janet wanted to deepen her response without going through a transplant, and Activism was right for her. Again, taking into the patient preference, clinical data to make that decision. What we saw in a clinical trial with Activism Lendex is that we had an improvement in progression-free survival versus placebo in 14.7 months versus, 20.6 months for the IRD arm versus the 14.7 months in the placebo RD arm. And you can see the Kaplan-Meier curves on here. Donna already mentioned that the safety and considerations, it's given days 1, 8, and 15, but it's also important to remember that the response was very quick. 1.1 months was the median time to response. So if you have somebody that might be progressing, now Janet wasn't, we just wanted a deeper response, but if somebody's progressing, you can feel pretty confident that within 1 cycle, they're going to respond to this therapy.
So Janet began treatment in January, and as part of her multidisciplinary team, I had her working closely with the social worker, who helped provide assistance with travel to and from the center, as well as providing some assistance at home. She's also followed by nephrology, given that she presented with renal insufficiency, as well as cardiology, as we want good blood pressure control given her renal status. So as of this month, I'm happy to report that there's no detectable monoclonal protein in her serum, and we will be doing a bone marrow biopsy next week to do testing for minimal residual disease.
As Donna mentioned, there is a relapsing nature of multiple myeloma. So Janet opted to deepen the therapy with Activism, and now she has no evidence of myeloma protein in the blood. She's got a complete remission, and they're looking to see how deep that remission is. At the beginning of the presentation, I showed you a black and white slide and focused on a line that goes down, because when you get your best response up front, it's hypothesized that you're going to be in remission longer, so you really want that big bang in the beginning. Joseph also mentioned that there's a prodrome, MGUS, monoclonal gammopathy of unknown significance, a period of time where there's an abnormal paraprotein present whether the patient knows that it's there or not, and then over time, the patient will progress to active myeloma, and through a series of remissions and progressions, ultimately, they'll become relapsed and refractory to the disease. This slide introduces you to the concept of clonal evolution. We talked about genomics and multiple myeloma and how they apply to nurses. I think it's important to highlight the different little pie charts on the slide. So what this researcher team did is they mapped the genetic clones of myeloma patients. So at diagnosis, and I think of them as bullies in the playground, so at diagnosis there was a dominant clone or a dominant bully that overarchingly needed to be treated. So you get rid of that clone, and as you can see, the third little pie chart is more green than red now. You can see that there's a different clone emerge because now they're not held down by that dominant clone. So that bully is gone and now another bully is emerging. That clone needs to be treated and maybe will now respond to a different therapy. So like this patient on this pie charts had Lendex and they went in remission, and then ultimately the clone is totally different. It's all blue at the bottom. That patient had transformed a plasma cell leukemia. And the importance of this is in suppressing clones, keeping patients on therapy longer, managing their side effects, which we'll talk more about later, and monitoring the disease as well.
So our third case, Mary, initially was diagnosed with standard risk myeloma in April of 2011. She began treatment with bortezomib and dexamethasone, followed by an autologous stem cell transplant. She achieved a complete remission after transplant. She also completed 2 years of biphosphonate therapy, given that she initially presented with lytic bone disease. So Mary did not want to continue on with maintenance therapy post-transplant, which is now something we would strongly recommend. However, we did monitor her frequently, every 3 months with labs, as well as she was being followed by her primary care physician for standard screenings. So Mary came back to us this past December after having 3 sequential rises in her serum free light chain, and now she was complaining of new back pain. So we worked up the back pain with a PET MRI, which unfortunately revealed a compression fracture at T10. So now Mary has her first confirmed relapse of her myeloma.
I think you've probably heard this today. My personal feeling and interpretation of the literature is that maintenance and continuing therapy to suppress the malignant clones is probably the way to go when we're managing our myeloma patients, if we can counterbalance the financial and the side effect management as well. This slide just depicts the idea of maintenance or continuous therapy and shows that there is data to support that. Progression-free survival in many studies is prolonged. People are in remission longer, and in some studies, it's a longer overall survival. I wanted to again underscore, however, the importance of survivorship care, encouraging smoking cessation and healthy behaviors such as more fruits and veggies and less high-fat food, decreasing the body mass index and decreasing the obesity as well, because we want people to be fit for that next therapy. We want them to not have a Charleston comorbidity index score that's really high. We want them to be healthy for the next therapy and if they plan on a future transplant. Infections are so important to educate our patients on as well. Joseph mentioned on earlier slides the baseline diagnosis of myeloma is cancer of the bone marrow plasma cells. They secrete immunoglobulins, which protect us from getting sick, but they don't work. So it's an inherent issue in patients with myeloma, and some of our newer therapies have really high chances of pneumonia. It's important to encourage good personal hygiene, avoid people with coughs and colds, and report symptoms that could be life-threatening. Steroids will suppress your immune system again, as well as some of our newer therapies. We can use some growth factors to stimulate and increase the white blood cells, and we can also administer intravenous immunoglobulin for this functional hypogammaglobulinemia. Again, you need the antigenic stimulation and antibody formation process to be effective to provide immunity, and that doesn't work. Immunizations are also important. This is a key nursing thing, is you can look at the chart and see when they last had their immunizations. A seasonal inactivated influenza vaccine is recommended for all patients with multiple myeloma, and the Centers for Disease Control recommend 2 vaccines for pneumococcal. The 13-valent Prevnar vaccine should be given once every 5 years, and then followed 8 weeks later by the 23-valent polysaccharide vaccine as well, and that's every 5 years. We know that multiple myeloma and bone lesions go together. 85% of people will have damage to their bones if they have a diagnosis of multiple myeloma. As you saw in Mary's case, she had disease progression at T10, and that was found on MRI. Most of the time we can do x-rays called bone survey, which is head to toe, about 20 films that look for abnormal damage to your bone, but MRI is a little bit more specific to finding damage. And you can see on this slide, there's the lucencies. It kind of might be a little hard to see, but it's important to make sure that the patient's bones are protected by not lifting heavy items greater than 10 or 20 pounds, depending on the extent of the bone disease, making sure they're taking calcium and vitamin D so they don't get hypocalcemia if they're on bisphosphonate therapy, and educate patients on symptoms of bone disease, such as bone pain. This slide reviews the importance of making sure that the bones are taken care of when they're on bisphosphonates such as pamidronate and zoledronic acid. So those two drugs in a head-to-head trial showed that they were equal in decreasing the risk of skeletal-related events. There's currently a phase 3 trial with denosumab, which many of you use for breast or prostate cancer. It's not currently recommended for myeloma, but it might be based on clinical trial evidence. If patients are on bisphosphonates, we usually give them for a finite period these days, about 12 months. They receive it monthly, again, either zoledronic acid or pamidronate. And then you can decrease the interval, some centers every 3 to 4 months. Some people, if they're in a great remission, will just stop bisphosphonates and resume if they have disease progression. For symptomatic vertebral compression fractures, a minimally invasive procedure such as balloon kyphoplasty or vertebroplasty can be recommended, or if there's active tumor, the plasma cell tumors tend to be very radiosensitive and radiation can be planned. Kidneys are very important, and it's so important to protect the kidneys. The high calcium levels, disease progression can also clog the kidney tubules. The renal tubular acidosis is a temporary renal failure which occurs when patients are dehydrated, so making sure that they're drinking fluids, avoiding NSAIDs. If they go to the ER with abdominal pain, make sure that the ER physicians know that they have myeloma so they can protect against the contrast dye. The treatment of renal insufficiency is to correct the underlying cause. How do we decide who gets what type of treatment? How fit are they? How frail are they? Are they eligible for transplant? These are things that we consider at diagnosis. At relapse, we think of what treatment did the patient have? Did it work? Did they have side effects? Maybe they now have neuropathy where they didn't. And considering these things are all important in the shared decision making. We also want to make sure that a clinical trial, if it's available, we have that discussion. The International Myeloma Foundation has this myeloma matrix. It's found online, and they have all these ongoing clinical trials for multiple myeloma, and there's about 363 of them by my last tally on clinicaltrials.gov. So maybe there might not be one down the street, but maybe in still close proximity that they would qualify for. And then finally, have you used all of the standard drugs to treat multiple myeloma?
So Mary completed kyphoplasty for her compression fracture, as well as we reinitiated the zoledronic acid for bone support. So we are very, very fortunate in this day and age that I have many options to offer Mary for her first relapse. I wouldn't have been able to tell you this a few years ago. So when considering which option is best for your patient is whether or not they have good support at home. So Mary is actually very fortunate. Her children live on the same street as she does, and she lives close to the cancer center. Some other considerations that we have to keep in mind is that Mary has chronic grade 1 peripheral neuropathy from her initial line of therapy. So in discussing which therapy would be best for Mary, Mary inquired about immunotherapy, something that she had learned about from a support group.
So we know that bortezomib is very effective in patients with newly diagnosed myeloma, and this study called the RETRIEVE study shows that if you retreat the patient, then they can go back into remission, especially in patients that responded with a greater than a partial response and relapsed greater than 6 months afterwards, because older studies with bortezomib had a finite period of administration, from 6 months to 8 months, depending on the trial. There was not an ongoing therapy with that drug. And we know that would be an option for Mary to consider. Adverse events include thrombocytopenia as well as peripheral neuropathy. And Donna shared with you, however, she did have grade 1 peripheral neuropathy, which kind of bothered her a little bit. So maybe retreatment with bortezomib might not be the right idea for her right now. Panobinostat is a histone deacetylase or HDAC inhibitor that was just FDA approved in 2015 in combination with bortezomib and dexamethasone for multiple myeloma and relapse disease. It's a pill that's given 3 times a week for 2 weeks in a row, and then you have a break. And it's given again, though, in combination with bortezomib and dexamethasone. If your patient is taking panobinostat, it's important to make sure that you know of their cardiac history because it can prolong the QTc interval in their heart. And it's also important to look for medications such as common antibiotics. Ondansetron is an anti-nausea medicine that can prolong the QTc interval. So know what your patients are receiving and know that it might impact their cardiac functioning. Acyclovir prophylaxis is also recommended, as well as labs to monitor the creatinine and calcium and potassium as well. Elotuzumab is one of the new immunotherapies that Mary was considering. She heard at the International Myeloma Foundation Patient and Family Seminar. They're all in many different areas. You can go to myeloma.org to find out where they are in your area. They're wonderful if you've ever been to them. But elotuzumab enhances natural killer cell activity. Like many of our myeloma therapies, natural killer cells, well, actually many of our patients lose natural killer cells as they grow older, but some of the therapies can enhance it as well as the elotuzumab. It's an antibody also to the SLAM-F7, which is signaling lymphocyte activation molecule family 7, and it works in a little bit different way as an immune therapy.
So elotuzumab is a monoclonal antibody, so there is an associated risk with infusion reactions. It's rather small at 10%, but of that 10%, 70% will have a reaction with the first dose. So proper pre-medication, so dexamethasone the day before and the day of, as well as a good H1, H2 blocker, acetaminophen, the infusion reactions are usually limited to a grade 1 or 2 and can be managed well. So we start the infusion slow at 0.5 ml per minute, and eventually it will be escalated to 5 mLs per minute by cycle 5. So that will translate to about 3.5 hours of infusion time. It's given weekly for the first 8 weeks, and then we switch to an every other week schedule until disease progression. Elotuzumab is approved in combination with lenalidomide and dexamethasone, so the same precautions. We have to make sure that our patients maintain the anticoagulation, and we need to monitor for the many, many, many side effects of steroids. So with treatment, we monitor blood counts frequently and adjust as needed, and we should be assessing response monthly as well. So Mary did elect to start treatment on the elotuzumab, lenalidomide, dexamethasone. As part of her multidisciplinary team, she works closely with her endocrinologist to help maintain her glucose levels with her dexamethasone dosing. So I'm very happy. After 4 cycles, she's had over a 90% decrease in her serum free light chain, and she's tolerating treatment very well with very minimal side effects. And we've really only had to adjust her insulin on the days of her dexamethasone dosing. Her pain is greatly reduced after the kyphoplasty. She rarely needs narcotic use. So in summary, for this section, induction therapy with 3 drugs versus 2 drugs is superior, but you really need to keep in mind who is your patient. Are they fit versus are they frail? We know that maintenance therapy improves depth and duration of response, and it's important that we understand that myeloma is a relapsing disease because of clonal evolution. And as nurses, it's important to educate our patients about preventing infection. Patients still believe the flu vaccine causes the flu, so we need to dispel that myth. And we need to promote good bone and renal health, make sure they're adequately hydrated. So we discussed 2 newly FDA-approved regimens for myeloma, Activism, an oral proteasome inhibitor, and elotuzumab, a monoclonal antibody.